Thank you for the opportunity to contribute to the launch of the Integrated Care Academy at the University of Suffolk. I'm going to talk about one aspect of integrating physical and mental health care. I'm going to focus on cardiovascular disease because that's an area that I've spent most of my career working in, as well as mental health. I'm David Thompson, Professor of Nursing at Queen's University, Belfast. This is a picture of the university where I work. To give some background and context of what I'm going to talk about, I'm going to talk about cardiovascular disease and mental illness, both highly prevalent and burdensome conditions. Health and social care needs for both and their services for them vary widely. And that's in terms of access, uptake, monitoring, and referral systems. There's a growing demand for these services, but they're faced with limited resources and with unpredictability. And there's also pressure from health and social care systems for cost containment, or what's often called value for money. And against this, there's obviously a need for providing safe, high quality care, which can be judged in terms of patient experiences and outcomes. Obviously, these services need to be underpinned by evidence, and we have to look at a balance between the benefits and the harms that they may confer. If we look at some of the issues in terms of cardiovascular disease and mental health or mental illness, in terms of cardiovascular disease, it's the major cause of death worldwide. It's also a major cause of disability and poor quality of life. So if we take England, for example, CVD cardiovascular disease, which comprises things like heart attacks, heart failure, stroke, and so on, are responsible for about between 1/3 and 1/4 or 1/4 of all deaths in England. And that equates to one death every 4 minutes. In terms of mental illness, that's also a major cause of disability and poor quality of life. In fact, depression globally is the major cause of disability. And it's estimated, for example, again in England, between 4 and 10% of the population will experience depression at some point of their life. As we all know, we're dealing with an aging population which is increasing. And people nowadays don't necessarily present with one of these conditions, but often with both, and often have other morbidities such as diabetes, pulmonary disease, and frailty, for example. This is compounded by stress, low social support, social isolation, low socioeconomic status. These are all important causes of ill health and poor outcomes. Looking at cardiovascular disease and mental illness is a fairly new concept. It's comparatively under-researched and it's often poorly addressed in health and social care. And obviously it's important for patients, but also for partners, families and carers. And I think it's important to remember that partners may experience one or both of these conditions or more. So what are the challenges? Well, obviously we want to prevent death and disability, but we also want to enhance their quality of life and well-being. And we can do that through various strategies, such as using disease management programs, risk reduction programs, health promotion programs. But these also need to take account of the distress that these people experience, as well as things like illness perceptions and beliefs that they have about their cause and management of these conditions, as well as health literacy. And as I've alluded to earlier, it's important to include patients, partners, families, and carers. And sometimes these are one and the same. And then there are challenges: where should these people be managed or cared for? Should it be in the hospital, the community, or at home, or or a mix. And it's important that we ask patients and families their preferences. And then we have to ensure that, for example, if they are in hospital, that there's a system of transition from hospital to home or to the community. And I think we can also draw on expert patients and lay support to enhance that experience. But as I say, taking account of patient choice and preferences. So in terms of potential solutions to manage these challenges, I think it's important that we use existing evidence-based theories, models, or interventions that are already there, rather than develop new ones. Use ones that we know are evidence-based. It's important to intervene early, timely, with simple, needs-led, menu-driven programs. Many of these can be simple, cheap, and effective. For example, giving advice can be a very effective intervention on its own, but also providing support, not just from health and social care professionals, but from families and friends. So it's important to involve patients, families, health, social care professionals, self-help groups, community resources and networks. And this provision of support and advice may be on an individual basis or a group basis. And it's important, again, and I stress important, to exploit available technologies, for example, e-health interventions, on mobile health interventions, artificial intelligence, virtual reality. These are all new technologies that are appearing very quickly and being developed and improved rapidly. But they have to take account of people's culture, ethnicity, language, and health literacy. So what are our knowledge gaps? Well, one of the key problems is that evidence and guidelines often differ from practice. Evidence and guidelines are based on randomized controlled trials often, or research evidence, which may differ from what happens in routine clinical practice. Interventions, services are often complex, often poorly described or evaluated, and so we need to be more precise about how we describe and develop these services. Comparatively few interventions or services are designed or produced or delivered by users, and I think this is something that is a gap that needs to be addressed and is starting to be addressed. Outcome measures that are often used can be inappropriate. They're often generic measures when it might be more appropriate to use disease-specific or condition-specific measures. And few of the studies that have been done are properly evaluated, replicated, or compared. So existing evidence is often not integrated into routine care, and that's a challenge. So in conclusion, I think it's important to use existing research evidence that's already there in health and social care, and there's growing evidence of what's effective, what is efficient, and what is appropriate. It's important to replicate and compare promising interventions and services. We're seeing a growth in the notion of co-design, co-production of new interventions and services, which involve patients, partners, and family members. After all, they are the experts in their own condition and what they need. And they should be involved throughout the entire process of care. We need to use appropriate measures in terms of outcomes and experiences. There are quite a few outcome measures available, but not many in terms of experience measures. We need to be creative, take risks, and exploit technologies which are developing rapidly. And finally, we need to be able to say that we can accept failure. Remember, if at first you don't succeed, try again. Thank you very much.